Okay. So welcome back from the break. We're going to try to get the session started. My name is Anita Asgar. I'm an interventional cardiologist at the Montreal Heart Institute in Canada. I'm joined by an amazing panel with Neil Pham, Edwin Ho, Paul Saraja, and of course, Dr. Greg Stone. We're waiting on Vinny Bapat, but I think for the sake of time and the live case starting at noon, we'll probably just get going. So I think I'm actually the first speaker. I'm going to be talking about transcatheter mitral interventions in 2030. Whoops. So I was asked to talk about what the future will be in 2030, transcatheter mitral interventions, and I thought I would retitle it maybe more like where will mitral valve disease therapy, a little bit more general, be in 2030. So I think the first thing to start off with is mitral valve disease at the outset is very diverse, and I put some of this here for you to see, but obviously it's not one simple pathology. There's lots of different disease states to deal with, and that's going to obviously affect the type of therapies that we're going to need as the future unfolds in front of us. I found this slide from Greg from 2013 from TVT, and I thought this was really interesting because this is 10 years ago. What was the device landscape like in 2013? Kind of a window to the future. And if we look where we are now, a lot of these players have fallen off the list. Some of these things are still here and still in development. So just to give you an idea where we came from 10 years ago and perhaps where we might be going. So where are we now in 2023? Obviously, in terms of transcatheter mitral repair, TEER is the dominant transcatheter strategy for both primary and secondary mitral regurgitation. We have 2 approved devices, and we have evidence both in DMR and in FMR. There are currently trials ongoing in intermediate risk DMR, and chordal repair technologies are continuing to develop, but it's been relatively slow. In terms of transcatheter mitral valve replacement, unfortunately, there are no approved devices in North America at the present time. Randomized controlled trials are ongoing. There's also EFS ongoing, but this has been a lot slower, I think, than most people had imagined or had hoped. So where do we want to go in 2030? What is the future going to look like? And I think it's important to break this down into more than just actually the technology, but to the other things that are happening in the space that is going to help us with mitral valve disease. First of all, imaging. We've seen huge improvements in imaging over the past 10 years with 3D echo. And now with artificial intelligence, I think there's probably an even bigger opportunity there. In terms of clinical decision making, we saw in the first session from Dr. Sharma how the guidelines may differ. However, probably we need a little bit more clarity on timing of intervention. And presently what we have is transcatheter repair and then obviously replacement in research. So if we start just with echo and imaging and what AI could potentially bring us, if you look back from 1985 now to where we are in 2023, AI is the big buzzword. We hear about it all the time, but there certainly is an opportunity in terms of valvular heart disease for AI to play an important role. And if we think about it, AI could actually be applied to image acquisition, view recognition, image segmentation, and again, disease state identification. It could potentially automate a lot of these things and make things better for patients in terms of getting faster referrals. In terms of image acquisition, there are programs already available to guide image acquisition, for example, suggesting other views or other measurements to make. View recognition, we could actually improve valve assessment by identifying data to allow for reading in stacks as opposed to in steps, automated measurements, and actually incorporate guideline criteria. And this was a paper that showed essentially how a deep learning algorithm can actually show that you can acquire echocardiograms relatively simply with even technicians who are not fully trained to get the data that you need. In terms of image segmentation, this is perhaps where the greatest potential might lie in terms of using sort of automated valve measures from 3D data sets to evaluate the disease state and to look at novel features associated with patterns on echo may help us to better understand and even stage patients in terms of the severity of their disease. This is another example looking at a TEE where you can actually use this data to build this data set. And if we can sort of imagine what the future might look like, perhaps these types of algorithms could help us better select patients from both the transthoracic and the transesophageal echoes. If we think about clinical decision-making and where we are at the present time, the current guidelines focus on symptom status, key echo parameters to determine eligibility for intervention. And I've put here the ACC guidelines for primary MR and secondary MR, not necessarily for you to read any of this, you already know it, but the key is we focus on some very simple parameters to try to decide whether a patient requires intervention or not. And perhaps it's overly simplistic, and we're not taking into effect more important things like understanding ventricular function as opposed to just ejection fraction, but really using other multi-imaging modalities such as MRI and CT perhaps to determine for our individual patients what that optimal timing might be. The other thing that's not in the guidelines that we should start to consider is utilization of biomarkers, better phenotyping of patients to select the appropriate intervention, but more importantly, the timing of that intervention. So this is another place potentially where AI might be helpful, and in terms of mitral regurgitation, this has already been started. This is a study that was published this year that looked at a French cohort using AI to analyze echo data to try to anticipate the response from mitral valve surgery, looking at a bunch of different parameters and trying to see what we can identify as parameters to predict the surgical outcomes, but perhaps more importantly, when is the appropriate time to intervene. In terms of transcatheter therapies, where we are now, we've seen the obvious importance of the heart team collaboration led to opportunities for patients to have a more comprehensive approach to treatment options, surgical repair, new approaches, for example, for mitral annular calcification. We've also seen, however, with the atrial functional MR and as well as tricuspid regurgitation, a new understanding of the impact of atrial arrhythmias, particularly atrial fibrillation, and perhaps new members need to be added to our heart team, electrophysiologists, to try to understand what ablation might be. But TEER does remain the dominant transcatheter strategy for repair, with a better understanding of patient selection in the past years and more complex anatomy and a better understanding of the outcomes we can achieve. Unfortunately, in 2023, TMVR is still struggling, and this is a slide I borrowed from Isaac George, and we can see why. There's multiple challenges, both in the anatomic challenges, device challenges, and the procedural challenges, which unfortunately we have not overcome in the past 10 years. Hard to know where that future is going. We do have identified what are the big issues: sizing, LVOT obstruction, difficulty treating different pathologies. We haven't quite found the solutions yet, so the hope perhaps in 2030 is that we will advance on that level. So what are the predictions for 2030 from a structural interventionalist? I think if we take those three components, so imaging, clinical decision-making, and therapy, and sort of fast forward, I think we're going to use more multimodality imaging for these patients and perhaps start to use artificial intelligence both for echo screening and device selection. It's going to be a little bit more comprehensive than what we're currently doing and finding a role for MRI and CT. In terms of clinical decision-making, I also believe that will become more comprehensive. And the timing of intervention is going to be a little bit more tailored to the patient, looking at different parameters, not just ejection fraction, not just regurgitant volume or LV size, but also incorporating perhaps biomarkers and other components that we're not currently looking at. We hear a lot now when we talk about TAVI, aortic valve disease, and the lifetime management of aortic valve disease, but we also have to think about the lifetime management of mitral valve disease. In the current era, all we have for transcatheter is TEER, but that's not all we're going to have. And we need to start thinking about, for example, patients with atrial fibrillation, perhaps a strategy of AF ablation. Once we eventually get a TMVR device approved, we're going to have to start evaluating TEER removal. Is that going to be something that we can look at for patients so that we can proceed them to the next step? Or how do we place these technologies in tandem so we can treat patients better? So overall, my predictions for 2030, I think AI software will evaluate echocardiograms, perhaps send automatic referrals for mitral valve disease. Mitral valve disease patients will undergo a more comprehensive evaluation, including extensive biomarkers, multimodality imaging, to evaluate disease stage and indications for intervention. I'm hopeful, although I'm not sure this will actually happen in 7 years, that the society guidelines will evolve to include more parameters, to be broader in determining timing for intervention, depending on the risk of intervention and the patient's disease stage. I also think atrial fibrillation ablation, I think we're already starting to see it in the EP literature, that we're going back from, instead of that rate control, perhaps backtracking now more to a rhythm control strategy. But maybe there's an option there to do ablation early and perhaps prevent or at least reduce atrial functional MR. I think TEER will be applied to an even broader patient risk population once we have intermediate risk trials that have been completed. And then hopefully new TMVR devices and new techniques such as Sesame, so actually scoring or opening the myocardium to address LVOT obstruction, will help hopefully address high screen fail rates. And then I'm hopeful that we'll have new tear removal devices that will become available for the lifetime management of these patients. Thank you very much.